keynote lecture. Over to you, Chairperson Dr. Jayakumar C and Dr. Yaseen.
Thank you. For the keynote, we have the next topic presented to us by our own Dr. Ajith Kumar S. Step in before it's too late. Referral guidelines for diabetic foot complications. Dr. Ajith is the Chief Consultant, Department of Hyperbaric Medicine and Diabetic Foot Care, SP for Trivandrum, Professor, Department of Internal Medicine, SUT. He is the Secretary of IPA Kerala. He is the Chairperson, Chairman and CEO of Diabetic Research and Care Firm, GC member of our system. He has several awards and publications under his belt, international and national. Welcome you, sir.
Very good morning. Thank you, Chairperson Jayakumar C as my teacher and friend. I think after the sarcopenia, we have a talk on diabetic foot. Basically, I will be concentrating on the referral guidelines for diabetic foot complications. We all know that diabetic foot is a very chronic complication of diabetes, and it is one of the major causes of hospitalization. The study says 20% of people with diabetes will have at least once in their life get admitted in a hospital for diabetic foot, and delayed intervention can lead to amputation. That is a miserable complication, and as a doctor we have to step in before it is too late, and we have to go for an emphasis of proactive action, maybe a preventive or maybe an intervention. This slide shows the significance of the diabetic foot in our country. In many amputations, that rough estimates India has approximately 45,000 of legs are amputated every year, but the latest study by the Australian agency shows that every 20 seconds somewhere in the world a limb is lost as a consequence of diabetes. So 15% of diabetes will develop foot ulcers and 85% of amputation following a small ulcer. That is a significance of early screening and intervention, because if we as a doctors, if we can identify an ulcer, even if it is a endometriosis or a small ulcer or a plantar ulcer, if we detect early, if we treat, we can prevent 85% of amputation. Way we want to prevent an amputation is the 5-year survival rate after post-amputation is 50%, and the coronary events will be very high after major extremity amputation. And you can see among all the deadly complications, I think this will be the leading third cause in the chart, because diabetic foot complications. So these are the numbers. 1 lakh legs are amputated in India, and as I said, 75% of amputations are performed on a neuropathic foot, which is potentially preventable if you do a proper screening. And if it's really economic wise, it is a very dangerous scenario. This average clinical in Indian clinical setup, 79% of doctors performs comprehensive clinical examination. So this study says, but the other study says fewer than 20% of the people get a foot examination. Problem with the diabetic doctors reported clinical cure rates of more than 80%, and you can see only 1.6% of doctors reported as a cure rate of 100%. And the major problem is the recurrence in diabetic foot ulcers, because the study says a study done by Dr. Vijay Vishnath in Chennai in 2005. He said the recurrence rate is about 33%. The data shows that the recurrence may be 18 to 22%. Why this problem exists is we may be sitting in a PHC or a CHC in an OP where 100 patients are waiting in a queue, and fewer than 20% of diabetic patients are regularly giving foot examination. You just introspect yourself. Yesterday we may have seen a lot of patients in your OP. How many patients' foot you have examined? How many of you will insist an individual to remove the shoes, the socks, and see the indento area or the sole aspect of the foot? We'll come, we will write some prescription, and we will send the patient. So it should not be like that. The major reason is fewer than 20% of the patients is getting a comprehensive foot examination. This is what I said. It's easy to do an amputation, but it is difficult to prevent its further complications. So as far as possible, it is better to prevent a major extremity amputation, because the 5-year mortality about 70% in diabetes patients. So the 4 mantras for physicians is basically you check, you protect, you treat. If you can't treat, you refer to the. These are the importance of the early referral. That means preventing an infections, improving the healing rate. That's very important, because you should work as a team. Because once we cross our border, I think the diabetic foot is entirely. Physicians work. In our state, it is basically a surgeon's domain, but I won't say it is a physician or a surgeon's domain. It is a possible, you try to reduce the amputation risk. That is our aim. So it will, if you do an early reference, I think it will minimize the hospitalization, because don't wait till a necrotizing fasciitis occurs or the toe becomes gangrenous. Even when you notice a small ulcer, if you can treat for your hair center, and most important thing is it will promote the quality of the leg. That is important for the patients, because yesterday when professor was here, he was a post-regional transplant patient, he was having a victor amputation. He used to consult me through the phone. I think yesterday when he saw me, he said, Ajith, I was very much depressed, so I used to disturb you every day sending progress, but I think now it is a very, very small ulcer and he is doing well. So minimum clinical information for the referral is you have to go for a detailed diabetes history. You have to look for the type of the diabetes, the year of onset, or maybe the duration of diabetes, what the treatment they are taking, whether they are sticking to the drug schedule, the medical history, especially the hypertension, whether he is a smoker or not, other medications what he are taking currently, certain people have got a tendency to take antibiotics for months and years, so don't do that. And recent A1C, vascular imaging, wound history and location is very, very important. Always rule out whether there is any claudication pain, because it may be an underlying POAD. Early warning signs are swelling of foot or ankle, very cold feet or legs, color changes, red, blue or black discoloration. That is very important. Most of the time the blisters, you may think that blisters. Or any evidence of early sepsis, it is better to refer to a higher center with multidisciplinary facility. So these are the high-risk foot features. If your patients you thick nails, cones, as such, foot deformity is very, very important. Whether it is a bunion, whether it is a loss of protective reflex, or whether it is a gangrenous changes, it's very important. And any patient who has got a previous history, maybe an amputation or maybe a small ulcer, and any patient who is a CKD patient, especially if they are on a dialysis, you have to give them more importance. So these are the certain rapid progression of the infection of neuropathic foot and ischemic foot. You can see the ischemic foot looks like this. Neuropathic foot is like this. You can see a lot of deformity. The claw toes are there, the mallet toes are there, because these points will act as a high pressure points, and when the patient walks with a non-protective footwear, I think they will have a callus, and slowly it will break and it can go into deep osteomyelitis also. So the referral criteria is basically based on the severity of the grading. See, previously when we were doing MBBS, it was only Wagner staging. Now there is Wagner staging is there is a Timmy staging is there, because nowadays all the guidelines which included ischemia, not only the infection, the ischemia also part of guidelines in the case of a wound severity. So anything with grade 3, 4 or grade 4, it is better to refer to a high center. Grade 3 is a deep tissue infection with an osteomyelitis. Grade 4 means some part of the limb is gangrenous. 5 means either the whole foot or till the knee region. So any infection or ischemia, you have to refer within 24 to 48 hours. Non-healing wounds within 2 weeks. Some books says 4 weeks also, but 2 to 4 weeks will be the safest range. High risk foot, you have to look for a regular preventive checkups. Referral criteria, you have to refer to a vascular surgeon or maybe a cardiologist who can do a peripheral angioplasty immediately if you are not getting any pedal pulses. If both the dorsalis pedis and posterior tibial or maybe below popliteal, because the diabetic foot problem is there is a diffuse involvement of infrapopliteal vessels. It may be a nightmare for the vascular intervention specialist to put a cannula, because multiple sites block will be there. So clinically if you get an ischemia, try to do a PCI, or if it is not possible, what you have to go for a what you call that graft. So non-healing ulcers of foot ulcer, presenting ulcer with previous history of ulceration, all these things you should refer to a vascular surgeon. You have to look for the depth of the ulcer, because most of the time it maybe looks like a benign ulcer, but if you put a probing or you put a take an X-ray and look for if there is a cortical erosion is there, and it is an indication of osteomyelitis. It's a big problem. And always look for pedal pulses. These ulcers you should not wait. So this is a paper which has come that prevention screening and about the referral of diabetic foot in primary care. You can go for the low risk, moderate risk and high risk stratification. It is available in the net. You can take it. I am not going into detail because of the time constraint. But anything above the moderate or high risk, you just refer the patient to a higher center. Especially anybody who has got a previous ulcer, or if they are not able to see diabetic foot management, you don't have to have a big sophisticated lab. You should at least have a 10 gram monofilament and a 126 Hz tuning fork. That is enough to identify the foot sensations. Critical limb ischemia is very, very important, where the perfusion of the lower limb is low and the pedal arteries is severely reduced. And if you have a facility for looking for a TCPO, to transcutaneous oximetry, that is the best thing. If it is less than 40 millimeters, it is an indication for doing a coronary the angioplasty. Or you can look for a toe pressure if it is less than 30. That is very easy, but TCPO2 is a little costly. This is what I was telling. Never hesitate to do a probing if you get some ulcer. You put a probe, and if you get a gritty feeling that you are touching a bony surface, then refer the individual. It will be osteomyelitis, especially the sausage toe, which is very common in our population. And either you can do a surgical probing and check. If the patient is affordable, the standard or the recommended investigation of choice is an MRI. Any ulcers which is not improving, that means less than 50% reduction of area after 4 weeks, again you have to refer. These are the categories. This is a simple test by which you can do. This is a limited joint mobility. You tell the patient to dorsiflex the great toe. If he is not able to do the dorsiflexion, sensations are not there. If it is impaired, you have to put them under high risk group and keep them under regular follow-up. So these are the red flags for immediate referral infected ulcer, sharp of foot. One point I to pay attention is there may be patients, they may be coming unilateral limb edema with redness or a swelling of that particular limb, and they may be years and years. Please don't restrict your diagnosis to a cell like this. If it is a unilateral limb edema with the redness, with the joint deformity, especially the mid-arch or the foot is collapsed, you just use a comparison of temperature of both legs. The involved leg is more than 2 degrees Celsius. With the normal leg, it is an indication of underlying sharp joint. So in that case, please don't continuously give antibiotics for years and years. If you don't detect sharp joint, 50% chance of amputation in next 3 to 5 years time. And referral pathway for diabetic foot is, as I said, foot examination. You remove the shoes, then see. Because sometimes the funny ulcer may be inside inlet or region, so you have to be very careful. Any systemic features, fever or resistant infections may be very, very important, and look for the neuropathy or the sensations. These are the working group of Diabetic Foot Federation guidelines. Anybody, level 1 is a general practitioner, then podiatrist, level 2 is a diabetologist, surgeon, level 3 is a foot care specialist. Multidisciplinary approach, you should have a physician who is good in controlling the diabetes or the insulin, endocrinologist, in ID specialist if your institution has got a policy, or you have to go for a local empirical antibiotic policy. And these orthotic surgeon, physiatrist, podiatrist, everything should be very important, and arterial blood flow, that is vascular surgeon. So these are the benefits. This was the one patient who had came to us 2 weeks back. He was applying some Ayurvedic preparations. You can see all the wound is young. 1 minute, please. So this is, you can see 2 ulcers are there. He applies some Ayurvedic preparation. He is not taking any anti-diabetic drug for last 5 years, but he is. These are the one young fellow, 35 years. He went to some, I think, Shabarimala without footing. Whatever we say, you wear footwear, he won't go. There was a very severely necrotizing infection, and with an increase in creatinine, I think he is doing well. I think it is in February. This is what I was saying. This is again a 35-year-old male. He is having a sharp out joint. You can see all the tendons has been infected. So if you do a proper referral at a place where somebody can manage and see this is his current status and he is doing well without too much of problem. So this is his dorsal view, because this area means it is going inside the bony cavity. So now he is absolutely fine. I think he is with the total contact cast and now removable walker boot. I think he will be okay. This was a case which was reported us 2 days back, referred from some, I think, Moatwood or something. You can see the ischemic thing. I think this person is having very severe pain. He is not ready to do the debridement. I think we put a whack. I don't know what will happen. We'll open it tomorrow, then we'll see. This is again another funny ulcer, ischemic ulcer. You have to be very careful. But this sort of ulcer, you have to rule out any venous incompetence also. This is the Government of India ICMR diabetic foot guideline. Evaluation of patients with diabetes. Whatever we have discussed, it is same. But always be careful about peripheral artery disease with neuropathic foot. Mild infection, and don't give antibiotics for unwanted infections. Periphery, there is a tendency called, if you are using Mox Clark 625 milligram, please use it for 3 times a day, not 2 times, and never start linezolid as the first line of antibiotics for any diabetic foot infections, because we will be in trouble, because it is one of the reserve drug for multi-drug resistant tuberculosis in patient. So this is the last slide. The active foot care, detective foot problem, high risk foot, moderate foot, low risk, you refer to the patient if you can't manage. So this is a summary of the criteria. So as I started, the foot problems are always preventable if we pay a little attention. Most foot problems are preventable through early identification, prompt treatment, and timely referral, and by skilled health clinicians. And if we can at least prevent one major extremity amputation, it is a very big achievement as far as the complications are concerned. Once again, thanks for Jyoti sir and JPEF for this opportunity. Thank you all. Have a nice day. Jai Hind.
Thank you very much, Dr. Ajith, for that extensive presentation and important messages for all practicing physicians. I think we'll take the questions now for the 2 talks we have. Any questions from the audience?
Sir, in your case, physiotherapy, structured and graded physiotherapy for a particular group of muscles, does it help sarcopenia?
You're right, but this will not preserve muscles or strengthen muscles. This will physiotherapy is mainly for the joints and less for the muscles, and this will decrease the rate of reduction in mass and function. Function will be preserved, but the mass will go down. So for that, you need to do resistant training with increased intake of proteins. 2 things are important to maintain.
No help with the anabolic steroid.
No, that is only the strength, the function and strength will be preserved, but the mass will continue to go down as we grow old.
Dr. Ajith, do you feel any patient who has no palpable peripheral ulcers has to be referred? Or
So if we don't have a facility to evaluate further, it is better to refer, because there may be severe, maybe another thing is maybe a calcified vessel, but it is better to do a Doppler. Then if you establish that there is an infrapopliteal involvement, it is better to refer.
Let me ask you a question, sir. Dr. Mittal, sir, most of these patients are statins. How does statin affect sarcopenia?
There is no direct evidence that they decrease muscle mass, but definitely accumulation of there is more incidence of progression of IGT to say diabetes. So that is there, but the muscle mass doesn't go down directly.
Dr. Ajith, about the shortcut joint of the ankle, what type of footwear you will advise?
So gold standard is, it is always total contact cast, total contact cast, total contact cast. But if the patient is not that, because most of the problem, the adhesion with the TCC is very important. So patients won't like that, they are putting a cast. So you can refer a walkable, a removable boot. A lot of companies are making it. They can remove, it is a Velcro attachment, so it is very easy to do that, because total contact cast, most of the time patient will be a little apprehensive, and you have to always rule out an underlying severe ischemic. And most of the time what we forget is, it is the the psychiatric issues which is associated with the diabetes. That is one of the most ignored area in any diabetic foot patients.
Thank you for the good talk. I'm a teacher for more than 32 years. It's unfortunate even now to see that even the postgraduates do not examine the feet properly. Properly meaning they have to examine the footwear also as part of foot examination. We see that very, very rarely. And India is a country where the feet are worshipped, but the diabetics are not examined. Thank you very much for the nice talk.
If there are no further questions, I think we'll close the session. Thank you.
Thank you, sir.
Thank you, Dr. Ajith.
I now request Dr. Jayakumar C to kindly present the token of appreciation to Dr. Ajith Kumar S for delivering the keynote lecture.